All right, welcome back to part two of our lecture. Just a quick recap. So far, we have been focusing on the depressive side of the spectrum, of the mood spectrum. That's where the pendulum been swinging. But now we are shifting gears and heading in the opposite direction towards the elevated mood, or what we can call hypomania or mania. So we are moving from depression to the other pole of the bipolar, if you will. And when someone cycles from one pole to the other pole, from lows to highs, and go back and forth, we are typically looking at a bipolar disorder. Now, I get it that this is a bit of an oversimplification. The actual diagnosis is much more complex, and we will dive into the DSM-5 criteria in just a bit. But for now, this is a helpful framework to keep in mind. So with that, let's take a deeper look into bipolar disorder and what that spectrum looks like. As I mentioned earlier, bipolar is divided into two different types. You have a bipolar 1. This is where symptoms are present for at least 1 week. And what are those symptoms, by the way? Well, this is when you have a client with elevated or irritable mood. You have a client who is telling you that I don't need to sleep. I don't need to eat. They have no appetite, and they feel good. At least they'll tell you that they feel good. They feel very energetic, and symptoms are present for at least 1 week or any duration if patient is hospitalized. Now, bipolar 2 is when the client is at hypomanic phase, and the symptoms are the same, but the duration is at least 4 consecutive days, and the symptoms are present most of the day, nearly every day. Again, symptoms are the same, such as elevated mood. They're very irritable, expansive mood, overactive. They talk a lot, inflated self-esteem. They do not feel that they need to sleep, and they also have increased sexual drive. Okay, so let's spend some time on the symptoms presentation for a minute. So let's back up for a second. Remember, you had a client on this side when we were talking about major depression, major depressive disorder, right? And if the client tells you, I can't sleep, or I am not sleeping, or you're asking this question, how's your sleep? Remember, sleep is really a psychiatric vital sign, right? I really ask that question. That tells me a lot, your appetite and sleeping habits. So if you ask these two questions to somebody that you believe has depression, and they'll say, yes, I'm having issues sleeping, and I don't have a good appetite, and they're worried about that. They want to sleep. And then the next follow-up question for a client who's depressed is, then how do you feel in the morning? They'll tell you they feel tired. They don't feel good. However, if you have a client who tells you, let's say you have, I don't know, a 25-year-old male who comes to your clinic, and then you're asking these questions, how many hours do you sleep? And they tell you, yeah, 3 to 4 hours. And okay, how do you feel in the morning? Their answer is going to be, I feel great. I feel good. I don't need to sleep. And how's your appetite? Oh, I don't eat. I have no appetite. I don't want to eat. And how do you feel? Well, I feel good. They feel good. At least they feel energetic, they'll tell you. And at the same time, they're talking a lot. Whereas a client who's depressed is going to be hypoactive, right? These clients are either jumping from one topic to another, very overactive, and most of the time they're working on multiple projects at the same time. They're working in the backyard, they have a project in the garage, there's something else is going on, in the kitchen, maybe, I don't know. In other words, they're working on a multiple projects. They're doing some research, and they're talking a lot to you, and the projects that they're working on, they're not able to complete any of them, so they're not necessarily productive, but they're working on multiple projects at the same time. And they have increased the sexual drive. They talk very fast. They're walking at a fast pace, if you will. As a matter of fact, they believe that you are very slow. Everybody's slow to them. So the difference between 1 and 2 would be for how long this has been going on. So 4 consecutive days is a bipolar 2. And the minute you have a patient in the hospital, when you're making rounds in inpatient psychiatry, the appropriate diagnosis at that time would be bipolar 1, because they're hospitalized, regardless of the onset of the symptoms. And when you have a client who is going back and forth, at my facility, I often get a client every single time when I make rounds. They're cycling, if you will. But when you have a client who is cycling more than 4 times a year, we call that rapid cycling. It is also worth mentioning that I do not want you to think that a client at a bipolar 2 are less impacted by this disorder, if you will, or they're not as severe. That is not true. Both individual bipolar 1 and 2 will get same or similar treatment, if you will. Maybe with the exception of, bipolar 1, if they are in the hospital, that's a different story, but in a psych facility. And mostly bipolar 2, if they're otherwise stable, you can manage them as outpatient. But the treatment protocol is pretty much the same. So I don't want you to think that bipolar 2 is less severe. The impact on their life is pretty huge. As a matter of fact, bipolar 2 client may ended up having more rapid cycling. So overall impact of this disorder is huge on these individuals, and we really need to identify them early on and adjust their medications. And I always give education on keep an eye on early signs. Are you losing number of hours that you usually sleep? Instead of 7 hours, 6 hours is like a 4 and 5. And how's your appetite and sexual drive? So these are some clues that we are not doing well, and perhaps make a phone call and ask a provider to take a look at the medications and adjust those medications early on, so that we can prevent these cycling episodes, if you will. Okay, this is just another way of giving you a visual presentation of a bipolar 1 and 2 and cyclothymia. So remember, when I had my, I was drawing my pendulum, and this side was the depression, and then here was the mania and hypomania, and then we were going back and forth. This is more of a horizontal description. So in the middle, you have this blue thick line, if you will, in the center. That's your normal, and my normal was right here, and I put N. This was my euthymia, and then here you have in the middle, it's the same thing. So when you have a client, let's start with maybe bipolar 1 green. So from normal to all the way to mania. So here's your green line, and coming down to depression and going back up to normal. So that's your bipolar 1. It's 1 because it's touching this manic phase. And then you have this maybe it's brown. I'm colorblind, so it looks brown to me. So from normal to hypomania, and it goes down to depression, and then here you are And then remember, I mentioned earlier that the term cyclothymia is when you have a client, if somebody's adult, the symptoms are present for 2 years, and if you have a child, symptoms are present for at least 1 year, child or adolescent. And then the deal here is that you have multiple episodes of hypomania, and depressive episodes, but they are not meeting the criteria for hypomanic episodes, and they do not meet the full criteria for major depressive disorder, but the symptoms are present. All right, so that would be cyclothymic disorder. So it's the same concept, just a different layout. Okay, so let's talk about the presentation real quick. Well, as we know, the bipolar is a disorder of early adolescent, maybe or young adult, you can say. Um, the symptoms are usually present, or the presentation is between 20 to 30 years with the mean age of 22. However, onset of these symptoms may occur throughout the life cycle. Now, talking about etiology, we believe that it's too much of monoamine neurotransmitters, so at least there's an imbalance of that. And please recall from your previous lectures that monoamine neurotransmitters are your serotonin, norepinephrine, and dopamine, and we believe that we have excess of these neurotransmitters. And remember, serotonin has to do with your mood and emotions. So too much of that, norepinephrine, those, autonomic nervous system, excitement, arousal, and so forth. And your dopamine, again, emotions, those type of symptoms. So when you have a client with these symptoms, of course, we want to do a very good patient history, their social history, environmental factors, because they tend to play a role just like any other mental health issues. Make sure we rule out some other criteria, such as pure insomnia, because if the patient has not slept for days and weeks, you may have a similar presentation. Alcohol or other drug withdrawal, especially maybe patient was on benzodiazepine, Ativan, Xanax, and so forth, or perhaps they were on some corticosteroids like prednisone or levodopa. So you can have a client who was on a long-term, maybe high dose of a prednisone, and then you see those episodes of psychosis, if you will, right? Or maybe levodopa, because remember, in Parkinson, the issue is that they have low level of dopamine, and when you are giving a medication to treat symptoms of Parkinson disorder, we are actually increasing dopamine for those clients. So make sure we always take a look at the medications or any other factor that can give you a similar presentation, especially if story is not matching. If the collateral information is that there was no symptoms present during high school or early young adulthood, and you see these new medications were added on, and then the symptoms are present, then it's worth taking care of those medications first. Okay, so very quickly I will go over the symptoms based off of DSM-5 criteria. I'll just do bipolar 1. The symptoms for 2 is going to be similar. The only difference would be instead of mania, you will have hypomania, but everything else is going to be the same, similar, pretty much. You remember, you have to meet major depressive disorder as well, right? So for bipolar 1, you have the following symptoms lasting at least 1 week, that are present most of the day, nearly every day, or any duration if hospitalization was necessary. So there are 7 symptoms altogether, and out of 7 you need at least 3 out of 7, or need 4 if the mood is only irritable, then you need 4. Okay, so remember the first one is inflated self-esteem, or the concept of a grandiosity. You have a decreased need for sleep. For example, they're only sleeping for 3 hours, but they feel good, they feel well rested. They're talking more than usual, or there's a pressured speech, if you will, right? Flight of ideas, racing thoughts, and they're very easily distracted. All right, so okay, and number 6 is they are involved with increased goal directed activities, either socially at work or maybe school, or sexually active, hyperactive, and then maybe involvement with some activities that can be potential dangerous or harmful or painful. For example, too much shopping, if you will, or making very foolish business decisions or investment and so forth. Okay, so again, take a look at these symptoms, and then make sure at the same time the patient is also meeting the criteria for major depressive disorder on this side of the pendulum again. Okay, now this is important. The episode is not caused by any other issues, such as rule out substance use disorder or some other medications, as I mentioned earlier, prednisone and so forth. However, if you have a client who was originally presented as a depressive mood, and then you maybe diagnosed this person with depression. Maybe you had a client, let me give you an example. Maybe you had a client who was 28-year-old male who presented to your client with the episodes of depression, and you had enough evidence, and the symptoms were present for more than 2 weeks and so forth, impact on the ADLs, and you gave them a diagnosis of a major depressive disorder. And when you did a good history, there was no mention of either hypomanic or manic episodes at all, and so therefore you could not have given them a diagnosis of a bipolar at that time. So the only presentation was depression. Remember, you had to start from somewhere. So the first presentation was depression. So you got a diagnosis of major depressive disorder, and you gave them antidepressant medication, let's say Zoloft and so forth. Okay. Now, after several weeks or maybe months and so forth, the patient come back to you, or patient was brought back to your office with the manic episodes, and you believe that those symptoms emerged after antidepressant treatment. Or perhaps the patient has a severe depression and we gave them ECT, and now you have a client with the manic episodes. Those symptoms are considered as a part of the criteria. That symptom is sufficient enough as an evidence to make a case of a manic episode. Okay, and therefore we treat that patient with a mood stabilizer. We'll talk more about the medication in a minute. So at that time, we must discontinue antidepressant and change our diagnosis. That person is no longer major depressive disorder. We need to change that from MDD to bipolar, either 1 or 2, based on for how long those symptoms are present. So that's a skill, and you must understand that concept, that we must change those diagnoses. The minute you see hypomania, along with the history of a major depressive disorder, that is no longer MDD at that time. That is at least bare minimum bipolar 2 or 1, based on number of days those symptoms were present. Okay, next, I just want to very briefly share some information, not necessary just for bipolar, but for any type of a mental health disorder. This is a good information to remember. From a DSM criteria standpoint of view, if we have enough information, we should try our best to specify the disorder. For example, in this case, bipolar 1 disorder, mild or moderate or severe based on the presentation we have, or do we have a client with bipolar with the psychotic features. We should specify if this is in partial remission or a full remission, and if we don't know, we can say unspecified. Remember, in DSM we use the coding unspecified when we don't have enough information. For example, maybe in the ER in case of emergency, but every effort should be made to get as much as information as soon as possible, by collateral information, patient history, and so forth, so that we can really specify the type of disorder. So for example, bipolar 1 with anxious disorder, or a rapid cycling, or with a catatonia, and so forth. So we really should be coding these specification. Another important concept, again, for any mental health disorder is to rule out other comorbidities. For example, for a bipolar, a good differential diagnosis would be ADHD. And remember, you have a client who is very young, so is it possible that your 22-year-old client is actually dealing with ADHD and not with a bipolar, because some symptoms may overlap. I know we haven't talked about ADHD yet, but there's a lecture that's coming up, so we'll talk more about that in that lecture. Another differential diagnosis should be substance use disorder, very, very important. Another interesting differential diagnosis is schizoaffective disorder. We'll talk more about schizoaffective disorder in psychosis lecture next time, but that's a good differential. Now, very interesting concept is the comorbidities. Can you have two different things at the same time present in your client setting? The answer is yes, of course. A very good or common comorbidity that goes along with bipolar disorder is borderline personality disorder. So something to keep an eye on. Again, we'll talk more about different type of personality disorders in a different lecture, but today just remember that borderline personality disorder and bipolar disorder are very commonly present. These are the two common comorbidities. All right, so let's say that you have successfully diagnosed a patient with either bipolar 1 or 2 based on their history, and now you are considering some treatment options. Just like anything in healthcare, we like to start off with non-pharmacological interventions first. That would be lifestyle modification, decrease stress and environmental changes and so forth, along with the psychotherapy. However, at the same time, you know that in order to go through psychotherapy sessions successfully, client must have some degree of intact mental status. Patient has to be alert enough to sit through those sessions and follow those instructions. So it may not be possible for some patients to be a good candidate for psychotherapy. For those individuals, we may go to the second step, which is the psychopharmacological interventions, and then once the patient is kind of sort of stable enough to follow instructions, then we can go back to psychotherapy option for them. Okay, now when we talk about psychopharmacological interventions, we need to know if the patient is stable enough to treat as outpatient versus, or do we need inpatient services for these patients? In other words, are we dealing with acute crisis or not? So once you make that decision, let's pretend for a second that this is acute mania and then patient is not stable to go back home. Then a decision has to be made to perhaps either admit the patient voluntarily if possible, if the patient is able to follow those instructions, or perhaps 5150. When the client is in acute manic phase, but not in psychosis, in other words, patient is not hallucinating and so forth, you can give them benzodiazepine. So that will help them to break that acute cycle, if you will. However, long-term use of benzodiazepine is not a treatment to manage someone with a bipolar. This is just to help with the symptom right now, like in the ER and so forth. Now, if you believe the client has psychotic features now, such as hallucinations and flight of ideas and so forth, then we need to give them a dose of antipsychotic medications such as Haldol. And I know we haven't talked about psychosis yet. It's coming up in the next lecture. But today, please understand, we are dealing with acute phase of bipolar symptoms. So please, you understand we have options before we really start somebody on mood stabilizer medications. Even though there's no such thing called mood stabilizer, we'll talk more about that concept in a minute. But the point here is, you have option of a plus minus using benzodiazepine to treat anxiety and treat non-psychotic symptoms, and plus minus use of antipsychotic medication such as either Haldol, that's a first generation, or you can use a second generation such as olanzapine, which is Zyprexa. I use that a lot, or risperidone. I use that a lot too. That's a second generation antipsychotic medications. Okay, so now let's talk about the actual treatment. As we know that bipolar disorder is a chronic disorder, so we need something to maintain these clients, keep them away from psychiatric facilities, if you will, stabilize their mood. We call mood stabilizer, even though that's not a medical terminology. A medical term is really a maintenance drug, or these are anti-seizure medications or anti-epileptic medication, I really should say. That's a correct terminology. And the medication in front of you are such as valproic acid, Depakote, my go-to drug. I prescribe this drug a lot. I have a special slide for this medication because this is a heavily tested item on the exam. So we'll talk more about that in a minute. Next, you have lamotrigine or Lamictal. It's a good maintenance drug. It's not as good to treat acute episode, but it's a good as a maintenance. We usually prescribe this as outpatient, not necessarily as inpatient. With inpatient, you'll see Depakote or lithium. We'll talk about those two drugs in a minute. Lamotrigine is usually a good drug, especially in children, adolescent population, and more specifically, a client who's pregnant. During pregnancy, we do not give Depakote, but Lamictal, or lamotrigine I should say, is considered safer drug, even though we know during pregnancy no drug is safe. There's not a single drug that is considered safe. And we'll have a special lecture on pregnancy or women's health later on, but please understand at this point that no drug is safe, but if we have to pick, usually lamotrigine is considered safer. One important concept with this drug is a rash. Make sure we give a good patient teaching regarding rash, Steven-Johnson syndrome type of concept. Carbamazepine, gabapentin, and so forth, that's usually add-on medications. Um, I don't, that's not my go-to drug, especially nowadays we have better options. So let's talk about Depakote as a maintenance drug. Even though we use this for acute, it's actually from FDA standpoint of view, it's approved for acute mania, but we use this for maintenance as well. We really don't know the mechanism of action. We believe that it can stimulate the synthesis and release of GABA. Remember, GABA is a neurotransmitter that is um, um, inhibitory neurotransmitter. It's going to inhibit an activity. Um, so think of a GABA as a brake pedals. It's going to stop, right, the activity. So when you have a client in manic phase, we want to stop that. So it shares this very similar pathology or etiology like a tremors, seizures, anxiety, mania, because the cell is very, very active. We want to arrest that cell, right? So what happened is we believe that Depakote A will synthesize and release GABA, and on top of that, um, it will also inhibit GABA degradation and reuptake. Remember, the GABA can also be destroyed by the enzyme and can be reuptake. So we're gonna stop all that so that we have increased concentration of a GABA here, so that we can calm our patient down. So it can cause sedation and calm your patient. It can also inhibit voltage sensitive sodium channel. We talk about a voltage gated channels, remember? So this is your cell and you have a voltage gate, and these voltage gate, they're saying sodium channel. You can have a calcium channel as well, but with the sodium channel, if we are going to, sodium is positively charged, but you want a negative charge inside. You want to block that. When you block that, you're actually blocking glutamate. That's another, glutamate is another neurotransmitter that is excitatory. So by blocking the excitatory neurotransmitter, you're going to calm your patient down. That's a good thing. So see how the concept is so beautiful. You want to increase GABA because that's inhibitory. You want to inhibit, and you want to block glutamate because that's excitatory. So working from a different angles, if you will, to achieve the goal of to calm somebody down. So wonderful concept here. Okay, needless to say, it can cause sedation because you're increasing GABA, just like with Ativan, benzodiazepine, and so forth. It can also cause tremors, nausea, vomiting, diarrhea, early, these are like a GI symptoms. But overall, I think Depakote is tolerated very well, to be honest with you. Weight gain, yes, that's I have seen it. So I keep an eye on those things. I have to be very, very careful because that can cause really like a metabolic complications. I have to be very careful with their lipid panels and A1C. Those are the things you will learn, that we have to be very, very careful with their baseline labs with a lot of antipsychotic medications as well. And this does carry a risk for hepatotoxicity and pancreatitis, thrombocytopenia. So the way I do this is I prescribe this drug a lot. The way I manage, I always get a baseline CBC, I get CMP, the TSH, and so forth. So when I start, I know the starting dose, people say 250 milligram TID, but I usually do like a 500 BID and then keep increasing to 750 BID and 1000 BID. So max is like a 2000 or so. And then I do CBC and LFT again in 2 weeks. And I also check valproic acid level in 2 weeks. So this drug has a narrow therapeutic range. It's not that narrow, but it does, you have to have a range. It's a 50 to 100. Some people say 120 or so. I feel comfortable around 100 some. Sometimes you have to push the dose as long as your CBC and your liver panels are okay. So be careful with that. Okay, for special population, for women, we know that we have to do the pregnancy test because the drug does carry the risk for neural tube defect. So it requires a lot of patient teaching. They have to use precautions and notify us as soon as they know that they're pregnant. Be very, very careful with that concept. Very important drug. You need to master this drug very well. Okay, next very important drug is a lithium carbonate. Um, Two main drugs really, Depakote and lithium, are, at least for me, my go-to drug. I have so many patients on it. As a matter of fact, a few of my patients are on both lithium and on Depakote. The way back in the days, people used to give a lot of lithium, but now what we're doing is actually, especially if the patient cannot or tolerate it because of a renal function, we give a little bit of lithium and we're adding Depakote. So we're doing both. But you can do lithium just as a monotherapy or just Depakote as a monotherapy and keep adding those two. Okay, we do know that lithium works very well in bipolar patient, but we don't know how though. So the mechanism of action is unknown, but we do believe that it modulates on the G proteins. Remember those G proteins, the drug enters, and there's like many other chemical reaction that occurs. There's a chain of reactions here, but the end result is that we are going to block the release of neurotransmitters. And remember, you have excess levels of neurotransmitters here, right? Norepinephrine and serotonin, dopamine, but we are going to decrease the release. We believe there are actually maybe 2 or 3 theories behind this, but we really don't know the exact action though. Now, one thing we do know is that it actually prevents suicide in a client with the mood disorders who have suicidal ideations. So significantly decrease or even prevent those ideation SIs. Now that's a very, very important concept. If you have a client and you have been documenting that the client has a suicidal ideation and then the diagnosis is bipolar, that clients deserve to be on lithium, at least to have a discussion that you want to consider lithium. They can refuse if they want to, but if they have a right to refuse, but that needs to be documented. And it's not you can only imagine how ugly that situation would be, that it was documented everywhere that the patient had SIs and we didn't offer lithium and patient dies. That's never a good feeling. So lithium has a narrow therapeutic range 0.6 to 1.2, so be very, very careful. The way I do lithium is I prescribe usually like 300 milligram, let's say 300 milligram BID, and then I check their TSH and CMP and basic lab work in 2 weeks. And then if I have to increase, I do increase, but usually I like to keep them around 1, even though it's 0.6 to 1.2, but I like to keep them 1.0 range. And then rule of thumb is about 900 milligram BID of lithium will give you about like a 0.9 range or so. So something easy way to remember, but you still have to do the lab though. You have to check their lithium levels. So don't just think, oh, it's a 900 milligram, because every patient will metabolize and absorb things differently, right? So, but rule of thumb is, at least what I have seen, is about 900 milligram will give you a serum level of 0.9, and you want to keep them between 0.6 to 1.0 or so. Okay,
keep an eye on the basic GI effect, that I'm not worried about that part, but here's the major issues. It can cause lethargy, sedation, but impaired motor coordination, ataxia, confusion. So those are your CNS adverse effect. So make sure you decrease the dosage at that time. That's how I usually don't discontinue, but decrease the dosage. If you have to DC, you have to DC. I get that part. But then you have to add something else like a Depakote. Now this is important. Hyperreflexia, tremors in fine motor activities such as writing, painting, buttoning clothes. Now that can be a big problem for somebody who's a painter. That's their full-time job, and we can mess up their entire career, if you will. So that's a conversation that needs to happen with the patient. If that's a correct medication and they are okay with it. For some people, they might be okay. They want to treat the disease or the disorder, and they wouldn't mind tremors then, and that's fine. Again, we have to have a discussion with our patient. Now, nephrogenic diabetes insipidus. So it's increased thirst, increased appetite. We know that, so that can cause that. Lithium can cause that, I should say. So check their labs at least every 6 months, if not annually. It can cause a cardiac toxicity, so sinus node bradycardia. So I always get baseline EKG for these patients upon admission, the first time we see them, and then every 6 months I do it. It can cause hypothyroidism. So lithium is toxic. It can suppress the thyroid hormone release. But when that happens, of course, I check TSH. Then I don't stop the drug, though. They need this drug for a reason, right? So we would treat that with levothyroxine instead of discontinuing lithium. And as we know, the lithium is teratogenic, so it can pass through placenta, and it can result in anomaly called Epstein's anomaly, where what happens is you have a lower displacement of a tricuspid valve. So if this is let's say this is the normal location, their valve will be displayed at the lower level. So, but they can, number one, try to avoid it if you have to, but then do the keep an eye on those patients, and of course that'll be a referral at that time, right? For cardiology, and they can intervene, and then I'm going to lecture on those concepts later on. So there's a lecture coming up for women's health and clients who are on these medications. Just so you know, certain drugs can increase lithium level, such as ACE inhibitors, ARBs, NSAIDs, and some antibiotic, so they can increase the levels. So with the tetracycline flagyl, these are like a short-term treatment, 5 to 7 days or so, but these can be long-term. NSAIDs can be long-term. Maybe patient has a chronic back pain, so we have to be very, very careful and monitor their levels maybe more frequently and adjust the dosage accordingly. You might have to decrease it. Here, these drugs can decrease the lithium level, such as potassium-sparing diuretics and thiazide diuretics and theophylline, the drug for COPD. All right.
Okay, very last important concept, I promise. We are talking about maintenance treatment of a bipolar. So the question comes up, can you have a client who has a bipolar disorder on antidepressant medication as a monotherapy on just one agent? The answer is no. Remember, we started our story on this side of the pendulum where you had a presentation of unipolar, and let's say that was day number 1, and we started this person on antidepressant medication due to major depressive disorder or unipolar depression disorder. Now, several weeks, months, or maybe years later, you have a new presentation. The pendulum is swinging on this side, and now we have a presentation of a mania or hypomania, and we changed the diagnosis to bipolar disorder, if you will, right? Either bipolar 1 or 2. Now, when you have a client with a bipolar disorder, the first thing that needs to happen is, when we change the diagnosis from unipolar to bipolar, we must discontinue antidepressant medication. They cannot be on antidepressant as a monotherapy. We must start them on one of those drugs that we have talked about, lamotrigine, Depakote, or lithium, or whatever you decide, inpatient versus outpatient, doesn't matter. The idea is that they need to be on mood stabilizer. Now, mood stabilizing agent can be monotherapy, and usually that is ideal, right? Either low dose of Depakote, let's say. And if you have to add another agent, if the mood is not stable enough, first make sure you max out the dosage. If the patient is on barely, I don't know, 500 milligram of Depakote a day, then do it BID or TID, and then keep it. I go all the way to like a 2,000 milligram a day, let's say, and then you can add another agent. You can add lamotrigine if you want to, or I do lithium, and then go from there, and make sure you always check their serum level of those drugs. Now, so it's okay to add on those agents, but we do not keep them on monotherapy. Now, a very important concept here is that either the patient or the family will come to you and they say, well, last time I saw you, you gave me a diagnosis of depression, and you gave me Zoloft or whatever the antidepressant, and that caused bipolar, or you misdiagnosed me. So the response at that time, of course, would have to be give them a proper patient education that that's not the case. The medication did not really cause the symptoms. It probably did speed up the presentation, but if the patient was going to have a bipolar, they were going to have those presentations sooner or later. Maybe this medication did speed up the presentation, but did not cause bipolar. I personally do not believe that is the case, and there's a lot of literature on this as well. Now, and let them know that it's not that we misdiagnosed you. At that time, we had no reason to call it bipolar because there was no presentation of hypomania or mania. But now we do know that, and therefore we are going to discontinue antidepressant and put you on a right medication. And there is strong evidence of efficacy on using antipsychotic medication with antidepressant medication such as olanzapine and fluoxetine. I know we haven't covered olanzapine yet, but we will in a psychosis lecture next time. Or we can give quetiapine, which is a Seroquel. Olanzapine is your Zyprexa, and a combination of quetiapine and lamotrigine. So you can have these combination, but not antidepressant as a monotherapy. And that's all I have. I know it was such a long lecture, but it was important, very, very important topic. And if you have any follow-up questions on anything that we have discussed so far, please do not hesitate to email me or contact me, and then we will go from there. Thank you so much for your time, and I'll see you next time.